want to give you all kudos for persevering for a full day of discussion. This has been very robust and deeply engaging, and we are so thrilled to hand this last session off to one of the most important people with us in the room today. And I am going to introduce the fabulous moderator, Dr. Ken Mayer, who will take it from here. As all of you know, Dr. Mayer is an incredible rock star in his own right. He's a professor here at Harvard Medical School and at the Chan, and he's an attending physician at BIDMC. He's also founder, co-chair, and medical research director at the Fenway Institute, which is the largest ambulatory facility caring for people living with HIV in New England. And he has led, as all of you know, in the response to the HIV epidemic from the earliest days through the breakthrough IPREC study, which demonstrated the effectiveness of HIV prevention. And so we are thrilled to have him moderate this session today with Ambassador Birx. Thank you.
Thanks. Good afternoon, everyone. It's a pleasure and honor to introduce the true rock star of the day, but we already heard about a rock star, Bono, earlier today. But Ambassador Deborah Birx is the coordinator of the U.S. government activities to combat AIDS. She's also the U.S. Special Representative for Global Health Diplomacy. Dr. Birx is trained as an infectious disease physician. She received her medical degree from Pennsylvania State University, trained in the U.S. military at Walter Reed, has assumed several other key positions in the global fight against AIDS, including overseeing the CDC's global AIDS program prior to her assuming the role of PEPFAR ambassador. What is really important about the talk that we're going to hear now is that what characterizes Ambassador Birx are three words that come to mind, or three phrases: evidence-based, results-oriented, and creative. And she has taken a very successful program, as you've heard about earlier today, and really continued to transform it and iterate it in ways that I think have unique salience to really address the epidemic, particularly now that we have exceptional tools, both in terms of treatment and in terms of modalities for prevention. So it's really a pleasure to introduce Dr. Birx and welcome her to the podium.
And you were extraordinarily brief, so that was superb, because I get very perturbed with long introductions. So you heard from Dr. Fauci, and you heard from Mark Dybul, and you heard from Eric Gooseby, and you heard from Charles Holmes. So it's a little bit like, and I watch a lot of sports, so being brought in when, it's the 7th game of the World Series, and you're one run ahead, and they're like, just finish it out for us. So, there was a lot of stress in taking on this position because of the work that you really heard from everyone else. That was really quite extraordinary. Each bringing their unique insights and really transforming the program in its own way. So I came out of the bench, and I had my own 6-foot hood for about 20 years, and that was a very soothing place for me. I was very comfortable with my T cells, and then ended up wanting to do research in sub-Saharan Africa. We did obviously a large clinical trial of a vaccine in Thailand, and we knew that we had to do really a validating trial. And the incidence in Thailand had dropped by so significantly that we powered that vaccine trial for an incidence of 0.2, which resulted in the largest vaccine trial ever done in HIV, or 16,000 people. But the people were between 20 and 30. Now, I don't know how many of you have worked with 20 to 30-year-olds around the globe, but keeping them on a clinical trial where you don't know if it has any support to their lifestyles at all for 5 years was extraordinarily difficult, but it prepared me quite well for PEPFAR. But what we started in 1998 was looking for field sites in Africa. And when you're investing millions and millions of dollars into infrastructure for field sites to do vaccine treatment, and every day out your window cartloads of individuals are coming to that hospital and being turned away by the matron, not because she didn't have compassion and feeling for everyone in the community. It was because, as she told me, if I treat them today, they'll be back tomorrow and they'll die because I don't have anything to treat them with in the long run. And this was 2-year-old children dying of pneumonia to moms and dads and grandparents. And I think it was difficult to see that every day and to realize that you didn't have the treatment resources, even though the treatment was available in the country that you came from. So when President Bush announced PEPFAR, I flew back from Kenya. At that time I was out in Kericho, to convince the office of Joe O'Neill, where this was originally run out of, that DoD Army should be engaged. And if you think that USAID and CDC had battles, you should have seen within the military. Because we're like, the Army-Navy situation. And so both the Army and Navy together were brought into PEPFAR, and that was really transformative for my career in general and why I ended up here today. So what we really tried to bring in 2014 was that same rigor that we brought to research to program. And to really, because we felt like if in clinical trials every individual was important, our programmatic piece, those individuals should be just as important. So we treat program like a giant clinical trial, but obviously we don't have a control to intervention arm. So what did we do? So as I described, we built on the strong work that both Dr. Ambassador Tobias and Ambassador Dybel and Ambassador Gooseby brought, and you could see by what Charles Holmes talked about, he was really a clear leader in this and working with Ambassador Gooseby. And then bringing the new science and technology as it was developed. Now, I started working for Tony Fauci because it was a joint fellowship in those early days with NIH, between NIH and Walter Reed. When he was working on Wegener's. And what he doesn't say is his breakthrough was using chemotherapy to treat autoimmunity, which was absolutely unheard of at that moment. In the 80s, you did not use Cytoxan to treat an autoimmune disease. Huge risk. People were very critical at the time. So when I took this job, the first thing that Dr. Fauci said to me was, thank goodness you have all the science and evidence to just end this epidemic, so just get out there and implement it. So I think, when your boss and your prior mentor says it can just be done, you just try to make it happen. And so it's really been a journey of trying to make this happen. You heard about these 3 phases of PEPFAR, and I think what we've really just brought to this is a little bit more granularity to the data, down to the site level, and then making that site level data available to everyone. So if you go to PEPFAR.gov today, you can see all of our 55,000 sites in every single country. They've all been GPS mapped, and you can see the data and the performance site by site. So we really tried to combine, PEPFAR was always built on results. And we moved those results to an impact validation results by adding community-based surveys, household surveys, to really document that program was having the impact that we needed it to have by measuring incidence and prevalence as well as access to services. And then putting that all on an open database so that everyone could utilize it and bring their individual insights to the program. We take partner management and active program oversight very seriously. I know there's some partners in the room. I know they will tell you that we take partner management very seriously by tracking the data very closely. So what are our 3 key goals? Well, in some countries, we want to, over the next 5 years, sustain the gains, to really ensure that we can sustain people on treatment. And you heard a lot of people talking about the issues that now arise in sustaining people long-term on treatment. We do have countries that are behind other countries, and so we want to accelerate the control of the epidemic in those countries. And then address the areas where there are rising new infections, and I'll go through those specific issues. But the majority of those countries are upper middle income countries that have key population epidemics. So my biggest issue has always been country ownership is not government-only ownership. It has to be community and government ownership. And if there's not that relationship between the community and the government refuses to respond to the epidemic that they have, then you have to find a new way of dealing with that epidemic. And I think even today, the countries that have rising number of new infections are almost exclusively key population epidemics. So I think we continue to push and provide leadership in making program data more reliable, validating the program data, both for the impact of the program, but the impact at the client level. And I think you heard from some of our incredible partners in the field that the understanding that data is only helpful if it really helps you serve clients better with a quality product. And then ensuring that communities are at the forefront. This was previously country operational plans, that's the way PEPFAR plans on an annual cycle, were done in the darkness of a room and shared with the government about 2 or 3 days before it was submitted and never shared with community. And so we brought communities with government at the table to plan from the very beginning of each of these cycles. And it's been really eye-opening to us, and I just want to really thank AVAC and HealthGap and other groups that have gone in and worked with communities to really interpret the craziness of PEPFAR data and the planning cycle. Because it's really empowered communities to have an equal voice at the table, because it doesn't help to have communities at the tables if they don't feel like they can speak to the data in the same way that often the public sector and the governments can. And the other thing that we're working on is finding out the actual cost versus what we're spending. And we believe there is a difference. We know what we're spending. We don't believe that that's what it actually cost. And so we're finally, this year, it took 4 years to get started, but doing activity-based costing in countries to really understand the costs so that we can take that in very clear ways to ministers of finance so that they can understand the cost of chronic disease and the chronic disease implementation. And that becomes really important as you talk about dealing with NCDs. So I think you heard from Charles the expansion that occurred. And a lot of that expansion, to be frank, occurred because we had a pretty large pipeline of additional funds available. Because the program expanded and we had uniquely, now for those of you who know government funding, most government funding, the money is 1 year money. And so you see a mad scramble in September to spend those funds and to get those out the door. When PEPFAR was begun, it was begun as no-year funding, which is never, I could tell you, having been in government now for almost 40 years, that never has happened. But it was one of those unique pieces that the Bush administration wanted to give everybody the maximum capacity to program to the best program rather than saying, oh, it's September and I got to get the money out. But instead saying, how is these dollars best utilized? And so for the first almost decade of PEPFAR, it was no-year money. And so that money never expired. And so you could use that for the best programming. About 5 years ago, it became 5-year money, but still 5-year money is dramatically different from all of the others. So you heard about how our budget has been flat since 2009, yet we continue to have to expand. We not only had to expand treatment, but we had to expand prevention. And you can see in the yellow bars how dramatically we've increased circumcision. We're well over 20 million circumcisions. And that was quadrupling circumcisions just in the last 4 to 5 years in a flat budget environment, and then doubling the number of people on treatment, again in a flat budget environment. But more importantly, being able to launch dreams. So we fully have 25% of our funds invested in prevention, and that was only possible because partners, governments, and communities worked with us to constantly increase the efficiency within the program. And so we're incredibly proud of all of the PEPFAR results. It's done in partnership with the Global Fund. Mark kind of made it, he said before, there was animosity sometimes between Global Fund and PEPFAR. I have to say, under his leadership, for the first time, we deduplicated every single program in every single country. That freed up almost $1 billion. Because we were, now what I've noticed in partners, if they're paid to do exactly the same thing by two different organizations, they don't usually come forward and say, you already paid me for that. When they lose money, they go to the press, but they never say when you're being paid twice for the same thing. And by freeing up those resources, you can see the Global Fund was also able, in a flat budget, to double the number of people on treatment. So this is what's possible. You heard about the 90-90-90. These surveys have been critical for us because these are well-powered, door-to-door, community-based surveys done in the field in partnership with CDC and ICAP in a whole series of countries to really go in there and find out how many people actually know their status, are they on treatment, and most critically, are they virally suppressed? And really, this data has allowed us to really understand where we are in every country and to understand where we are in different geographic regions in those countries. And that has led to this community viral load suppression of over 73% in almost 10 countries. Now, the caveat behind this and why you still see young women getting infected is because you can achieve 90-90-90 and still being missing 50% of the men between 25 and 35. So let me say that again, because you saw that men had lower prevalence. So you can get to 90-90-90 and be missing all of the men in that country, or at least 50% of them, between 25 and 35. And so that's what's hidden in this. So we require every country, every geography, every age band, and we do 5-year age bands. You cannot be declared having reached 90-90-90 until every population, both genders, and every age band is at 90-90-90. And I think Botswana, and I'll show you their data of why we think that transmission is still happening. So they have screened now through these surveys over 350,000 participants. In Nigeria alone, it was 200,000. So that's 500,000 people that have had door-to-door surveys within the last 4 years. We're now repeating this cycle. Haiti is undergoing a cycle right at this time. And now we're repeating the second year of surveys to give us trend lines and incidence. Because we saw, there was one country where we had a baseline, Swaziland, and we saw over almost a 50% decline in incidence in 5 years. It's only been 2 years, but that's the kind of acceleration that we have to see if 90-90-90 is going to translate into actual control of this epidemic and validating those pieces. So here's the tricky part, because we often talk about incidence and prevalence. So behind all of this, and as opposed to the United States, in most of sub-Saharan Africa, there is both either a youth bulge, a bulge of youth coming through the system, or a youth wave that is predicted to continue to 2050. And so even though incidence and prevalence is declining, the actual number of individuals at risk each year is going up by 3 to 5%. And so we have to constantly be dramatically decreasing the rate of new infections because the denominator keeps expanding. And so what drives cost is the burden of disease. So you have to prevent new infections despite the fact that you have a larger and larger and larger group at risk. And since the beginning of the epidemic, the actual number of young people in sub-Saharan Africa has doubled between 15 and 24. And so in Uganda today, the median age is 14. On the continent, 60% of the population is under 20, and they will become 22. So every year, there's an ever-increasing number. So in southern Africa, Namibia, Zimbabwe, Botswana, South Africa, there's a youth bulge. And so there's this group of adolescents that will move through, and then that's pretty steady state. In Zambia and the rest of sub-Saharan Africa, it's a youth wave. And so you can see just by this pyramid that there's an ever-increasing number of 10 to 24-year-olds headed into the highest risk exposure group for HIV. And so combating that at the same time, and it was one of the critical reasons why we launched DREAMS, because if we didn't shut off the tap pretty quickly, it was going to expand to a place where governments, Global Fund, multilaterals, and bilaterals couldn't afford the burden of disease that was going to exist in sub-Saharan Africa. We talked about incidence, we talked about prevalence, we talked about the denominator continuing to change, and we talk about the burden of disease driving the cost for everyone, for both prevention, because if you have more and more women, young women who need PrEP every year, as well as structural interventions, and you have more and more people needing treatment, it becomes a non-sustainable piece. So when we talked about creating sustainability, our focus became, how do we control the epidemic so it is sustainable? Because we were getting to a place where no one could afford the depth and breadth of the epidemic, particularly in sub-Saharan Africa. So here's just a cartogram of the burden of disease just to remind people. South Africa right now has 7.9 million people in need of treatment. So, and headed to, of course, over 8 million fairly quickly. So this is really an amazing driver. Now, because of the FIA, the analysis of the survey, Nigeria is no longer number 2 in burden of disease. It's now been replaced by Mozambique for 2 reasons. Mozambique's new infections continue to rise, and Nigeria's epidemic has been right-sized based on the survey, where it decreased the epidemic size by almost 50%. And so I'm going to take you through these pictures. This is based on the spectrum model, but the surveys in the field have validated the spectrum model. Now these models, instead of showing you incidence and prevalence, I'm showing you the absolute number of new infections and the absolute mortality, all-cause mortality, of HIV-positive clients. And so you can see in Rwanda, you're under R1. And there will be a whole, and the incident rates that they are going to release puts them well under and well above what control of the epidemic looks like. And so we have a series of countries that have achieved or are achieving what we would call control, where the mortality exceeds the new infections. Now this is because almost 50% of the population in places where they have control are now over 50. So by having the demographic age bands on all of our treatment programs, we know precisely where everybody is and their ages. And so this changes the calculus and the discussion in many countries. This is what Namibia looks like. This is what Eswatini, formerly Swaziland, looks like. And you can see that dramatic change in the rate of new infections over the last 5 years, where we have really focused on decreasing the new infection rate. Here's Kenya, Ethiopia, Malawi, Lesotho, looks very much like Swaziland, Zimbabwe, Uganda, Botswana, Zambia. We still have work to do there. Tanzania, where we have to really still decrease the number and the rate of new infections. The absolute number, this is Cameroon, Nigeria. This includes all their new data. So you can see, if I had shown you this 6 months ago, it would have been a flat, high line rather than a declining line. Côte d'Ivoire, South Africa, really the dramatic work that they have to do because their epidemic is so large. And then Mozambique, which in all of our groups, of our key focus countries that were part of the original PEPFAR investment, Mozambique stands out. South Sudan, we've increased our investment in. They've been in conflict, so this is, we've not been able to really move as many resources to South Sudan as we have wanted. I just want to call attention to the axis. So you can see in this slide that the top line is 180,000. This one is 20,000. So there clearly is a very different rate of new infections or absolute number of new infections, and Angola. And we're very excited about Angola with the new leadership in Angola, because the First Lady and the President have really taken on the HIV/AIDS epidemic, and the First Lady in particular really wants to ensure that every pregnant woman is treated, and we want to, with them, implement PMTCT in a comprehensive community-based approach where everyone in that family or in that community is also tested, and we think that could be very successful. So here's the pyramids that I'm talking about. Here's Botswana. Here's their whole demographic pyramid shown in gray coming from the World Bank. And then their HIV pyramid based on surveys and our data. And you can see that majority of clients are over 50. This also outlines who knows their status, who's on treatment. And this gets into this issue. And you can see the number of orange on that male side. Those are the individuals who know they're positive and are not on treatment. Lots of men are in that. And this is Namibia. So again, you can see it within their population, and then you can see the pyramid. So as countries develop more and more of control, shutting off the new infections in the under 25 age group and the aging of our population because they're on treatment and successfully on treatment and virally suppressed and living long, you'll see these adjustments in the pyramid. And so whereas in many countries the demographic pyramid looks as it does on your left, in a successful controlled epidemic, your HIV pyramid should look as it does on your right. And that is our goal, where people are thriving with HIV, but the number of new infections, particularly among young people, continues to get smaller and smaller and smaller. And so this is how we're focusing, and this is how countries have demonstrated their ability to do this. In countries that are achieving this profile, we test 100% of the new diagnoses for recency, and were they infected within the last 4 to 6 months. That allows us to refocus our prevention intervention in almost an outbreak sort of way with the government. And so that's been quite exciting. So I wanted to bring something else to your attention. So this is new data. I always like to and you all have done some amazing work here. So I wanted to show you, these are countries, Kenya and Zimbabwe, very similar epidemic from the beginning. If you look at those curves, you can say that Kenya and Zimbabwe have a very similar curve in reducing and the rate of reduction of the total number of new infections and the mortality. And then if you look at Malawi and Tanzania, they're both axes of 200,000. The other axes are 300,000. So you can see their lines should have been closely related. So then I give you the community viral load suppression from the surveys. Kenya 73%, Zimbabwe 73%. Tanzania only 60%, Malawi 73%. And then I'm going to show you the investments. So what I did is I've added up all the global fund expenditures for HIV, all of the bilateral program, ours, PEPFAR, expenditures in that country. You heard earlier that the government expenditures are usually in the 5 to 10% range. I did not include those. In the orange line, it shows the total dollar expended to achieve that community viral load suppression. So in Kenya, we've spent almost $7 billion to do the same thing that only cost $2.4 billion in Zimbabwe. And I think this then starts to really allow us to interrogate the countries and try to understand why did it cost 3 times more almost in Kenya to do the exact same thing as Zimbabwe. And part of it is they didn't have any other resources and they wanted to control their epidemic. And so Zimbabwe, just by sheer need, was able to focus their resources in a more effective way. Then if you look at Malawi and Tanzania, Tanzania's almost spent $6 billion. They have lower community viral load coverage than Malawi. Malawi spent less than $2 billion to achieve the same thing. And so these are the kinds of things we're trying to understand, because we think if you want to tackle other outbreaks, other infectious diseases, NCDs, you've got to understand these differences in countries' performance and the investment. Because when we talk about what it cost to control the epidemic, it's taking all of this data. So it's saying that you need as much money as Kenya when you only may need as much money as Zimbabwe. And that becomes a very different discussion when you're talking to ministers of finance, who are looking for the most efficient and effective way to achieve health for their citizens. I put all of the other data in here from all of the other countries so you can see how all these countries line up for every country that has done a FIA or one of these surveys in the field, where I can really stand very clearly and tell you this is the burden of disease and this is what the community viral load suppression is. And you can see Kenya far outstrips any other country. But then when you start looking at the countries that have received less resources and have smaller epidemics, when you look at Rwanda, they've spent over $2 billion to achieve the same thing that we are getting out of Lesotho and Swaziland, and the Lesotho and Swaziland costs are very comparable. So these are the kinds of the next generation of questions that we have, because we believe that these will be really critical answers for as we try to expand and try to have countries achieve their goals in the SDGs of universal healthcare coverage. I wanted to also talk about Vietnam. They've been an extraordinary partner and a key population, and like Thailand, have really begun to control their key population epidemic, and the same with the Ukraine. Now, we really wanted to understand those differences in expenditures and progress. So a lot of people had said to us it was the health system and the wealth of the country that really drove the ability to respond to epidemics, because that would make sense. If you had a better health system, then you could respond more efficiently and effectively. So this is all HIV new infection trends. That first line, the bottom line is 40%, the other line is 30%, and really showing the progress. The brown countries are PEPFAR countries where they have made a lot of progress. I wanted to also show you the slide because it puts out a stark difference between what we used to call generalized epidemics and concentrated epidemics and their ability to decrease the rate of new infections. And you can see that it's a lot of countries above the 0 line, and all of them are key population epidemics. So across the board, as a community and a global community, we've made much less progress in key population epidemics as generalized epidemics. So then we asked, well, could it be the health system? And so this is using the WHO criteria. We didn't grade the health system. We used WHO grade of the health system. And so along the x-axis, you see the health system index, strength of their health system around the 6 building blocks of the WHO health system, and then you see the changes in new infection. Obviously, you want to be on that side of the 0 line, but there's some very strong health systems that have actually increasing in new infections, including Russia and Pakistan and others. So health system strength alone did not predict success. And if you just pull out then the PEPFAR countries, you can see we have some countries with very low health system scores that all have declines. And you can see where Botswana is, and this, I'll get to that, why they were in that position on that graphic. And this just looks at ART coverage. I just put out the quadrants, 0.5 for health systems, so that's halfway up by WHO criteria. You can see the majority of countries that have 80 to 90% ART coverage are in the quadrant of having the weaker health systems. And I think this just goes to show that countries can overcome a lot of their weaknesses with incredible political will. So then we looked at, well, what about richer countries? Because maybe richer countries are doing more for their population than poorer countries. So this is just GNI. And if you look at it, obviously, there's no relationship between wealth and decreasing number of new infections. In fact, the poorer countries actually did better. And I think this is really because of the generosity of both the countries who contribute to the Global Fund and to PEPFAR in the United States of stepping in when many others wouldn't. And then this is the change in new infections, again, broken out by PEPFAR countries. And you can see that the majority of countries with the greatest success have under 2,000 as their GNI. So there wasn't a relationship between health systems. There wasn't a relationship between wealth. This is, again, looking at GNI versus ART coverage, and again, the countries with low GNI have equal, if not better, than countries with higher GNI. So then we went back and said, well, this is kind of intriguing. What really makes a difference? And so political will really matters. Just like when President Bush announced PEPFAR, he gave us the cover to fail spectacularly, to be honest, because it was a presidential initiative. Now, no one ever lets down a president, but in general, he said, I want this done. I realize that no one has done this before. We also realize that a lot of people have talked about it, and the United States is now going to act on it. But it gave you the ability to try things that have never been tried before. That's what countries did. Countries tried things that had never been tried before because in the end they wanted to stem originally the horrific death rate in HIV. Because remember, when we finally found out we had an epidemic, there were a lot of late-stage clients, and so that was such a reality. Now, political will matters because it's the political will that drives the ability to have the policies changed. And not just policy change sitting on a desk in the Ministry of Health, but ensuring that the Ministry of Health has written every single health center and every single district hospital with that policy change in a circular. Now, it took us 14 years into PEPFAR to realize how important these circulars were. Because for 14 of the 16 years, they said to all of us, oh, we made that policy change. We were like, oh, thank you. And then we realized that none of the sites were doing what the government said their policy change was. So I went back to some ministers that I really trusted, and I said, well, what's the disconnect there? And they said, well, you didn't ask us to write a circular for each of the sites, and that's the only way that the sites will make the policy change. And so even though our partners were doing everything to get, to do test and treat, because the government hadn't written the circular down to the site, our partners were really having a horrific time of getting the sites to do it because it wasn't policy that was in their circular book. And I think bringing the policy from the capital city did not help. It had to come in a circular to the site because that's how they have done business for 50 years. And so this became really a very important piece. But also we think data matters critically because it allows us to see past our perceptions and assumptions to what really is happening. And it gives us trend lines of what every site is doing and if they're improving or whether they're not improving. So again, political will allows us to work together in a real way. And frankly, it's the only thing that makes our US taxpayer dollars work, is to have that political will and policies to have the changes that we need. Now, what it has also allowed us to do is push on these policies related to our investment. And this year, we really pushed to really eliminate fees, both formal and informal fees in West and West Central Africa. And that's what you heard about in Nigeria. Going state by state in the case of Nigeria, because that's how they work with the governors, makes it more complicated, but we're there and doing it. Governors had changed their policies and eliminate the fees. What was happening is we were never going to get past 50%. Because when 50% of the women are so poor that they cannot pay the $2 or the $5 for the ANC card, and it's a difference between their child getting an immunization or them going for their ANC visits, this is the kind of situation we have put people in. In addition, the informal fees that were driven by the formal fees resulted in everybody taking money. So yes, a viral load was free, but you had to pay somebody under the table to draw your blood. So this became impossible to execute programs in West and West Central Africa. So Cameroon, Cote d'Ivoire, and Nigeria are working very hard to get this change and have made informal fees illegal, and they're policing. And we have hired, learning from the Global Fund, a whole group of community advocates and activists who are now going to sites and ensuring that it's happening. So there are eyes and ears every day to ensure these fees have been eliminated. So this is kind of a real juxtaposition of political will. So, this is the difference it makes. So same epidemic, Russia, Ukraine, Russia, every year, rising number of new infections. Ukraine, every year, decreasing number of new infections. And this is just what has to be done at the highest levels of government in order to get this response. Now, I put all these other slides in here in case you wanted to review them. These are all the policy changes that occurred over the last 6 months during our development. Granular data. The granular data is important because it allows us to see who we're missing. Because we have the surveys, we have census data, we can tell precisely who we're missing. And we have 3 primary issues in implementation. Number 1 is access to services. So I think I'm going to echo Mark when he says if one more person tells us that we haven't done health systems or integration. We integrated into the health system that existed. We built an additional health system to support totally integrated into their structures in every country. But I can tell you building it did not make them come. Because young people, particularly young women who are not pregnant, and men of all age group until they're desperately ill, avoid all clinics. Because it's a sense of weakness to go to a clinic and to be seen with the mommies and the babies. And so unless they break something, which is one of the primary ways we have been finding them, is in essentially the ER, because they've injured themselves, they really do not want to come to the clinic. Retention, particularly losing young people, because we haven't adapted the program that very much was set up to serve the sick to serving the well. And it's a very different program. And if you want to deal with NCDs, you have to figure out how to get the well into the clinic, because it doesn't help to find the people when they had the stroke. You want to find them 10 or 15 years earlier with hypertension. And then we do have a small group that is retained and not virally suppressed. We've been doing deep dives into this. A lot of these individuals are individuals that were started on nevirapine as children and maintained on nevirapine as adults. And so we have forbidden our commodities group to buy nevirapine, and now the Global Fund and Peter Sands has done the same thing. But in some populations, 20% of the population was on nevirapine, despite not being recognized or recommended by the WHO for a number of years. And so it's not enough to say the policy and the policies are in the circular. You have to go in and actually see what's in the pharmacy. So we worked very hard to understand precisely who we are missing. So the surveys that I talked about, this looks at men and women across a whole series of countries taken together. So we've not found a lot of children, particularly children over 5. There's a whole group of children over 5 that haven't been found because the assumption was made that the majority of children, 80 to 90%, would be dead by age 5. Well, shockingly, these children have been remarkably resilient, and they're alive. And so now we have to find them, yet our programs were not set up to find a 10-year-old. So we are really now working on, we now have all the women in treatment, so we're trying to now get all their children tested. And you can see the large disparity, particularly in men, 25 to 35. And young women, 15 to 24, that are not yet pregnant, haven't interacted with the healthcare delivery system. So these are well individuals that have no reason to come to the clinic or think they need to come to the clinic. Now this is Uganda, and I just put this up as an illustration. Every country and every minister of health today can get the data and understand precisely what age bands, what gender are missing. And this is at the country level, but they can do it at the district level, and they can do it at the provincial level, and really show you who they're trying to find. And so you can see that in Uganda, the women, 96, 100%, 97% of women are on treatment. And this is the success of B+, and maintaining women on treatment that got started as lifelong treatment during pregnancy. You'll see that it drops a bit in the plus 50-year-old women, and these are women that may have escaped B+, that got short course AZT or short course, the option B or option A, and then never came back to the clinic to get restarted on treatment. And then you can see the red and that big red band at 20 to 29-year-old men. and really understanding what we have to do to find them. So then they take that with the absolute number of people, and they can show you precisely who is missing and what the numbers are. And that becomes critically important because you have to know how many you're supposed to find. And so translating these percentages into absolute numbers become critical. You can see in the female side, the largest number is over 50 or is in the 15 to 19-year-old age band. And so this tells you you have to find two very different groups. So if we didn't have this data, they would just think, oh, it could be anybody in any of this. But what you need to do to find a woman over 50 and what you need to do for a 15 to 19-year-old are very different. And it allows us now geographically to translate this again into what needs to be done at each of those sites. Now this is Botswana's data, because Botswana has made tremendous progress and got to 90, 90, 90 on paper. But the problem was this big wheel of men. And so this is who's missing off a treatment. That tiny little wedge, that's about less than 25%, that's the missing women. The rest of it, the 76%, is all men. So 21,000 men have not been diagnosed. 33,000 have been diagnosed but are not on treatment, and another 20%, another 20,000 are not virally suppressed. So all told, there's a missing 75,000 men. And so finding them out of a population of 2.2 million becomes critical to really understand where they are and how to find them. Because you can't do everything everywhere, and so it becomes a very focused agenda. So once you know who you're missing, then you have to know how you're going to test to find them. So this is, again, Uganda's data. I'm just staying with Uganda because for consistency. This is how they're finding men and women. So they're still finding women primarily in this pink. And again, it's district by district so that they know precisely what they're doing district by district and where they've historically found people. So 55% in general are found, of women are found still in A and C. But you can see that varies district by district. So it's not only one size doesn't fit all. It's not one country, probably even not one district. It's got to be community by community by community. On the male side, we're still finding, now that big green block that you can see and the little green block that's smaller, TB clinics and inpatient. The men that we're finding in Uganda have less than 200 CD4 cells. They are presenting with late-stage disease, and they're presenting as inpatients. So this is what you never want to see. This is where we were 15 years ago. And for all the progress we've made with women, men have not gotten the message. So we have brought in, we work very closely with the private sector, and we brought them in under MenStar to really go out and do focus groups with men. And it's been very illuminating because all of the assumptions that I have made about male behavior were completely incorrect. So that's why, again, it's important to get the data. The biggest influencer in a male's life, no matter what the age, is his mother. Usually I see a lot of males going, I get that. Men believe that their mother, rather than their partner or their children, is solely on earth to have them as their number one priority. And there's no conflict. They know that their mothers, out of love and altruism, want what's best for their sons. And so we never thought of going to find the mothers and telling them that it's in their son's best interest to get diagnosed with HIV. So that was a huge insight. The other surprising insight was men only want to see other men, which I never would have taken into account because I came up in a generation where there was just nothing but male OBGYNs. Can you imagine saying you'd only go to a woman? I mean, it wasn't even an option. But men only want to see men. They think we are talking about them. I told them they're not that interesting. I mean, really, when you're busy as a nurse or a physician or a community health worker, you are not focused on gossiping about the men. But the men are very concerned about that, so they only want to see male providers. And so countries are moving to male providers in specific areas of clinics male nurses, male physicians, and hours specifically based on when that community wants to access health care. Some of it is on the way to work, some of it is on the way home from work, and really meeting men where they are to get them engaged in their own health and their health care delivery. And this has been very exciting for us, because if we can figure this out, think of what we can do in NCDs. So it's quite exciting. Retention, the biggest retention problem is really under 35, mostly well clients who are initiating treatment for the first time. And part of it was we only had a ephedrine-based therapy. I think now that we have TLD, the results will be different. But young people particularly have significant side effects to ephedrine-based regimens. And when they were well when they came in and they took the drug and they feel sick, it has not been good. I'm not going to go through the Haiti and the Uganda data about what they're doing. And we heard a lot today, so I added this slide in on using the PEPFAR platform to drive overall health improvements. When the high-level meeting on TB came, it was very interesting to listen to TB providers, because they really are like the downtrodden of the three diseases, because they've been at this a long time. And I don't know if you read a lot of Winnie the Pooh, but it's a little bit like listening to Eeyore. Oh my, we don't have this, and we don't have that. And they're like, and we have to find 20 million people. And I'm like, we do that? I mean, that's what we had to do. And PEPFAR, you gotta just, get excited about this. And so we've been stepping in, particularly in the areas where we can help. So screening 100% of our clients for TB, if they don't have active TB, getting them on TB preventive therapy, and screening their families, and screening the community, and really working with our TB colleagues to change that. Cervical cancer investments, because we couldn't. President Bush, when he left the presidency, met a woman who was dying from cervical cancer after she had been on ART, and he just said, we cannot have that happen. We cannot have young moms now dying from cervical cancer. And so we've really been working on screening and then bringing primary prevention, particularly to HIV positives. Now, there is a potential for hypertension and diabetes, but I will tell you what our problem is at the end. And this is how far we've gotten with TB screening in less than a year. And I just want to thank our scientific advisory board, who also came up with these very clear suggestions and metrics. And this is our investment in cervical cancer, but it's just been a multi-million-dollar investment. And already we've screened more women in the first 12 months by focusing on HIV-positive women who are the most at risk. We've screened more HIV-positive women in 12 months than we did in the first 5 years of the prior work that really was letting anyone be screened HIV-negative or HIV-positive. Now, hypertension and diabetes. We have two big issues. One, we need access to the hypertension drugs. And you might say, oh, that's easy. A lot of them are generic. Well, they're not WHO pre-qualified. And no company wants to pay to have their dossier reviewed. And WHO has said to me, well, just buy it. And I'm like, no. US taxpayer dollars cannot buy a drug that isn't either FDA or WHO pre-qualified. So we're now in this circular reasoning. And it costs about $250,000 to get these drugs reviewed. So that's what we're talking about. And we need probably three drugs. So $750,000 to make these drugs available, because they're fairly inexpensive. And we already have the infrastructure and the health providers. But I can't make the drugs be pre-qualified. So that's a big issue. And then we have to figure out how to get the men in the clinic. Now, we did try a big hypertension in our seeking of men. We did offer everything that Diane had in her health fairs at the facilities. And it did not increase men uptake at all. Now, maybe if it was Cialis and Viagra, I don't know, but hypertension did not bring them in any way, nor did diabetes. So if you build it, they won't necessarily come. And I think this is really, we can't just be flippant about NCDs. We have to figure out now what it's going to take to really provide prevention for everyone and to really get them into the clinic. So finally, on prevention, you heard about DREAMS. It's very much focused on young women now 9 to 25. We have a very aggressive program in circumcision. We're well over 20 million circumcision. We have an aggressive condom purchasing program, and we have an evolving PrEP program. Our big problem is this HIV positive men right here. Because you can see in every country we're missing about 50% of them. And so the data can look excellent, but you're going to have ongoing transmission if you're missing the majority of men. You know from the TASP study that if your viral load suppression is under 50%, you do not impact incidence. So this is circumcision, which is going well, and you can see we're well over 20 million through the first 2 quarters. We continue to buy a lot of condoms. They're not adequately distributed, and they're not adequately distributed to young people. And then our dreams countries, we reached 4 million young women, and the reason we're so excited about this is it's structural. It's focused on young women. It's focused on listening to young women, and that's what's so exciting today about listening to all of you. So thank you, and thank you for your time and effort that you put into this, because it was a great conversation. But really putting them at the center, listening to what their issues are, working on parenting program, working on community programs, but all around ensuring that young women can thrive in their communities. We work at keeping them on school. In Malawi, we're investing $80 million to build schools. And the government is providing the teachers to find enough desk and desk space to keep 100% of girls in secondary school. And because of that, this is where the incident declines that you heard about earlier. This is district by district incident declines in the first 2 years of execution. And then these are the districts where we have less than 25% incident declines, and we're still working on why this is not happening. And then this is a summary where you can see the majority of districts, 85% or so, have significant declines in incidence in young women. It's focused in the districts with the highest prevalence, and we don't move it to another district until that district is saturated. And so right now we're saturating Blantyre, because there was a lot of real estate in Blantyre that really did not have adequate access to this program. There's a lot of PrEP expansion within DREAMS. It took us 2 years to get governments to allow us to move to providing PrEP outside of sex workers and documented sex workers. So this is our first opportunity to really get PrEP to young women. We'll think that we'll surpass the United States numbers probably within the next 18 months of execution. And I just wanted to end with an issue that is very close to my heart, and this is the frank rape of young children, particularly young women, as their first sexual experience. And so the majority of young women who experience rape is often under age 15. It is often their first sexual experience. It's anywhere from 25 to 40% of young women's first sexual experience is rape. And so we really have to address this in country after country and provide an environment where this can be reported and there can be prosecutions. This sexual violence continues through their lifespan. We continue to evolve our OVC program because we realized a lot of the rapes were happening in 9 to 14-year-olds. And so we're really working with our OVC program to increase the age group that they're focused on. And then finally, we're working to transition to local partners. And I just want to call out Harvard, because there was only 2 universities that stepped forward to really say that they would engage in PEPFAR. There were many universities working in sub-Saharan Africa. But many universities didn't want to take on the liability or being associated with a program that was providing services rather than research. It was a very difficult thing. And then after they went and did this, we said to them, oh, by the way, out of the goodness of your heart, would you transition to local partners so that you put yourself immediately out of business? And they did it. All 4 of those treatment partners developed local partnerships and local partners that now in all of our analyses are doing as well as the large international partners that we bring into the countries. So we have documented evidence now that the local partners that were developed by Harvard continue to thrive 9 years later and are providing extraordinarily quality services. And that transition happened because the partner did it. I mean, PEPFAR asked them to do it, but it's hard, and they did it, and that is really quite important. CDC will be at 70% local partners within the next 12 months, and we'll believe USAID will be somewhere between 60 and 70%. So finally, I think PEPFAR was, and you heard it today, groundbreaking because it changed global health forever. And how did it do that? United States acted when everybody else was just talking. And I think that was really important, and I think it really set the tone. Because the United States took the risk of the potential huge failure because we went forward with a plan that had never been tested. And I came out of the military, and they said, that's when, your plan completely changes within first engagement. I mean, we didn't have a first engagement, yet we went forward anyway. And this was really possible because it was a presidential initiative, and it had the full backing of the White House. And you can see how many times Dr. Fauci described the White House having to engage. And the president made it clear from the beginning that he was taking the risk, and he had everyone's back. And I think that really made it possible for people to take risk. There was continuous communication between the scientists and the program, and that continues till today. And that has been the absolute critical element in all of our innovations and our success. It's the only program that's still, there's communication continuously between communities and governments, and that's equally important. It's the only health program that continues to match results to accountability and dollars, and so that we can track and trace every US government dollar from the American taxpayer down to the site of implementation. It changed forever a policy about accessibility to drugs. And so in PEPFAR, there's an FDA waiver that allows the innovator companies to immediately transfer the license for resource-limited settings, and that's been happening continuously. It built the current health infrastructure in many of the resource-limited settings. It's obviously trained hundreds of thousands of new health cadre. But it now provides the structure and the platform to address future pandemics and health security. And it is the pathway to universal health access if we can tackle this young people, well, and men issue, which I think is really critically important. And then finally, this continuous use of data. We collect data quarterly and analyze it quarterly. Many of the partners collect weekly and monthly data. It allows us to constantly identify our failures. And that is just as important as our successes. It allows us to see success at the site level, define it, and take it to scale. And when I say scale, I mean, last year we did 85 million HIV tests, so it takes us to scale. And then I think critically for those of us who work in the health field is it allows us to see past our perceptions to our clients' reality if you use data correctly, and allows us to validate our impact. And finally, it's helping us find fraud and corruption. So we can really triangulate data now between the survey and the program reporting data. And so we have been able to find fraud in partners who have made up their results. Because when the viral load suppression doesn't match the fact, if they say they have 90% of the population on treatment and the viral load suppression is 50%, something is wrong. And that's allowed us to find that. So thank you for your attention, but more thank you for all of those you presented today so that I could listen to all of your great work and really applaud Harvard, not only for its CFAR and its great science, but for taking that risk in PEPFAR and really standing behind that all of these years. And you could see the product of that when you have investigators standing up presenting from these partnerships that you develop. So thank you very much.
Ambassador Birx, thank you for a bravura presentation. I mean, that was a tour de force, and we're so lucky to have you doing what you're doing. So if folks want to come to the microphone, we're towards the end of the day, but we certainly want to entertain questions. So one of the biggest challenges you have is now that you're thinking about NCDs and you're embracing HIV uninfected at-risk people with PrEP, what goes into the mix, what doesn't, and what stays out. So for example, viral hepatitis, 2 vaccine-preventable diseases, highly prevalent, high morbid consequences, and then obviously hepatitis C, treatable. of curable infection?
So our surveys have begun to include hepatitis B and hepatitis C. I will tell you in our most recent report, our hepatitis C is tiny, and the co-infection is minuscule in the places we've done surveys. Hepatitis B is about 3%. Hepatitis C well under 1%. And so this really goes into our analysis. But I think, obviously there's a lot of companies that are making treatment much more affordable. And certainly particularly our key population, people who inject drug programs, we are looking at this very carefully. But I think that's the trade-off. I mean, it seems like a lot, and it is, $6 billion of your money. It's a lot. 1.5 of that goes to the Global Fund. So we have about 4.5 billion. But we're in 60 countries and constantly trying to understand how we should move our investment is really key. And once you get to steady state, do you move some of those resources to the countries who are still behind? Do you take on NCDs and supporting the government in the countries that have made progress? It's a good problem to have, but it's a real discussion. Thank goodness we have a scientific advisory board.
Which will be meeting next week, yeah. People, please come to the mic if you do have questions. But another issue, the same question I asked Dr. Fauci earlier today. So do you see, in the foreseeable future, can you see future programmatic innovations that will give you more funds to get that additional 10 million people on treatment? I mean, it's a big lift, and the likelihood that there's going to be a huge bolus of funding in the immediate future from Congress and the administration doesn't seem highly likely.
Well, this really comes back to a policy piece, because in the countries where we work, we believe that we'll have 90 to 95% of everybody on treatment. The question is, and I'm going to just be very frank, what do you do about Indonesia? 15% treatment coverage. Spent $130 million of Global Fund money. I mean, what do? India, about 55% ART coverage. So, these are real questions. What do you do in upper middle income countries that have more concentrated epidemic, that haven't responded to the epidemic that they have? And I think that really becomes a broader question. Certainly doing more of the same is not going to get us to a different place. So there will have to be innovation and shifts in the way governments approach their epidemic in order for there to be a change.
Shabnam, please.
Thank you so much. I'm Shabnam, and I'm from Pakistan. Thank you so much for the wonderful work that you've been leading. We've heard throughout the day of the successes throughout this journey about the consolidation of gains, the innovations which have been scaled up in other countries within PEPFAR, the systems, and you just mentioned about the systems, structures that have been put in place, which can also be used to address future pandemics, and the examples of cervical cancer has been quoted by you. I just wanted to know now, with 15 years of immense experience and having these systems and which have been tried, tested, what is the vision of PEPFAR for a wider sharing in an institutionalized manner with other countries where PEPFAR is not working, because I feel they can hugely learn from this investment which has gone into it over these 15 years. Thank you.
That's a great question. And I think, we work now very much regionally, and really we have never thought of inviting the other countries in the region. And I think we do have the mandate to do that, because a third of the Global Fund dollars, often that are in those countries, are US taxpayer dollars. So, facilitating the ability of those countries to have a greater impact is important, I think, to the US taxpayers. So I think that's a great question, and we'll take it back, because we meet in the region, yet we bring in just the countries that are receiving PEPFAR dollars. And I think it's part of the reason why in every country where we are, we've expanded past, like in Burundi, we had, there were PEPFAR sites and Global Fund sites, and now they're just sites. And we work together that closely. And so we'll go back and we'll ask the Global Fund and see if they think that would be an issue.
Shubha.
Thank you. That's a fabulous presentation.
it seems like your last slide seems like your heart is set in moving towards UHC and move and.
I think the world is set on moving towards UHC.
But you're
I don't know how we will. I will be honest. We
Yes.
will, in countries that have had great success in controlling their pandemic, then we can have that dialogue. But in countries that haven't reached all populations, gender, and age to viral load suppression, it's a more difficult dialogue.
So if you can expand on the cervical cancer screening and treatments and some of the successes and challenges, because the screening is not easy, and linking for the treatment, if you can elaborate on that.
Yeah, so the cervical, we were actually the founding member with UNAIDS, Merck, and the Bush Institute and Gates Foundation, very much in Pink Ribbon, Red Ribbon. And that was announced by Secretary Clinton. It was a wonderful initiative. President Bush is always impatient. So when we took that data back to them 5 years in, he was like, what? You need to be a lot better than this. And so we really sat back and went, okay, this is our opportunity to really look at what worked, what didn't work, how do we figure this out, who really is at risk. And researchers, again, the science was so much better than when we launched Pink Ribbon, Red Ribbon. 5 years later, there was excellent data all across sub-Saharan Africa about the subtypes, the risk to the subtypes, the age of infection, dual subtype infections. It was incredible, as well as the unique risk of HIV positive clients. And so we went back and said, we owe it. We have I just showed you 90% of women are already in treatment, and they're not all being screened. So we owe it to those women first because they're at the highest risk. What was interesting to us is the number of subtypes that are circulating. And so we've been in conversations with Merck for HIV positive young women to get them the multivalent, 9-valent vaccine, because we think that makes more sense. Now, of course, that puts us in opposition with WHO sometimes. So we're still going to move forward on that, but we think, there is a unique database around HIV positive women and their unique risks. And so we're going to spend the next 24 months getting to 100% of the women we already have in treatment, and then having discussions with countries about what to do about the broader screening. Because we screened, I think, close to 650,000 women through Pink Ribbon, Red Ribbon. The majority of them did not have lesions. And then we got very nervous about the data that talked about spontaneous reversion from lesion to asymptomatic. For those women out there who've had atypical pap smears, that's not uncommon. And so you can have atypia on your acetic acid screen that reverts on its own about 80 to 85% of the time. Then I got worried, what were we doing? And in that do no harm piece, treating repetitively with cryo or thermal coagulation of young women's cervixes that would have reverted on their own, that made me nervous. So until we really understand that, I think we really need to step back and think about HPV DNA for those women that are HIV negative, and then following suspicious lesions without intervention rather than directly always intervening, because I think we just don't know what repetitive cryo and thermocoagulation does.
So assuming the DREAMS initiative is successful, and it will, since you've launched it, you alluded to this, the epidemic in sub-Saharan Africa is going to be increasing an epidemic affecting key populations. Many of the host countries are not always the most sympathetic to civil society around key populations. How do you anticipate being able to navigate that moving forward to keep the programmatic initiative going forward?
So this is, I think, a big question across the South in the United States and in many places we work. And I think we have been very dogmatic about risk and putting people in boxes, and I don't think they see themselves in that box. And that's particularly been difficult in sub-Saharan Africa. So the majority of the individuals that we talk to that are having sex with men do not consider themselves as having sex with men. I will tell you it happened in the military, so it's not uncommon. So if you're having anal intercourse and you're the insertive partner, that is just sex. That's not homosexual or heterosexual sex. And I think that's a very difficult conversation. And so if we focus solely on key populations and use MSM, we will be missing probably a significant part of the population. And it's part of the reason why we launched this universal access for men to treatment and prevention services based on their risk profile. Just talking about sexual behavior rather than who is the partner. And we're trying to get more honest feedback about how to move forward. And this was very common in Thailand. When I started there in the early 90s, we didn't understand the third gender and the role of the third gender, and no one considered that MSM behavior when you had sex with a katoi. So I think these are trying to really understand cultures in a way that we can actually have a public health impact. And I think we're still searching for that, particularly. We have great coverage among sex workers and people who inject drugs. And so those, like in the United States early on in the epidemic, who would have thought that the most successful intervention early on were the people who inject drugs, and their incidence dropped faster than anyone else's incidence. So we see that now overseas, particularly in those epidemics, but now the MSM epidemics are crossing those lines in many of the populations. And so I think really understanding how we do better, both on the prevention side and the treatment access side.
Yeah, I think the crux may be disentangling identity and behavior.
Yes.
And also training healthcare workers to be able to
Yes.
provide non-judgmental counseling.
Well, you're going to help us with that, right?
Of course. Yes. Anyway, last questions or comments? If not, I really want to thank the ambassador for spending the day with us and giving us such a wonderful talk. Thank you. That was wonderful. Thank you.
So I want to bring this session to a close with just a couple of comments, and one is sort of a personal reflection. It has really been amazing to go from seeing a patient in 1980 in the emergency room with a new disease that we had no idea what the cause of it was, and recognizing it as pretty much a death sentence, to a situation where we have one pill once a day that can give people essentially almost a normal life, to a situation now where in fact that treatment is available throughout the world, with aspirations you heard today that are realistic, that we'll have 95% of the people that need treatment ultimately on treatment. And it's really PEPFAR that has moved the needle on that last aspect. And it's been just such a joy to listen to the talks today. I want to thank the speakers from Tony in the beginning, who launched this day's events off, but really was the driving force behind everything that we talked about today. And I think Tony's leadership has just been extraordinary in terms of what he has done for science in the U.S. and for approaching this incredible epidemic. I want to thank all the rest of the speakers, both local and national and international, that really gave us a sense of the many dimensions that have had to be dealt with through the PEPFAR program. And then finally to Ambassador Birx at the end, who I think really outlined for us what some of the ongoing challenges are going to be. I also want to, like Ambassador Birx, acknowledge Harvard and the role that Harvard has played in this. You know, there's been an incredible basic science approach here, but Harvard is a place that has many dimensions and many different schools. And you heard from the School of Public Health and the medical school and the law school today, and from people from the hospitals. And there has been a concerted effort from the very beginning to bring all those different parts of Harvard together to address this. And I think we can take particular pride in the fact that Phyllis Conkey put that grant together to be one of the first implementers to really take these advances to the world. I also want to thank the organizers, Ashish Jha and Ingrid Katz, and the rest of the people at the Harvard Global Health Initiative, the CFAR, the Petrie Center, and the Center for Health Law and Innovation that all helped to co-sponsor this today. And finally, I want to thank the audience for all of their participation today. It's really been a very memorable day. I think we have an extraordinary amount of success to celebrate, and I think we have a lot still on our plate that needs to be taken care of. And I know that Harvard will continue to be in with both feet, and I think from what we heard today, all the people in this room will be continuing to commit to really putting this epidemic behind us. So with that, I think we should give everybody a round of applause, and then and I want to invite you all to join for wine and the poster sessions, the poster session at the back of the room. So thank you very much.